getting really to the low back complex, how crazy all this is. Prone position does give you access to getting compression on these erector spinae structures, and that is important, don't get me wrong, but the positioning of doing that, I'll demonstrate once we get a person actually on the table how to get on those. But that's where ergonomically I see therapists have the most difficulty, is trying to get to the middle of the table on this very tiny spot and deliver enough pressure, especially for a person that wants a lot of pressure. That's a tough one. And if you don't put the pillow underneath of them and you're squashing their pelvis and low back down to the table, it can all just be an ouchy time. So you can get on this just fine in sideline, where they can come up closer and nearer to you. Prone is a common one. I will show it. But if I was gonna really tell you the one to just bother with trying more and getting really good at, when somebody has more symptomatic low back related dysfunction, that's their main goal. They're coming to you for relief related to this. This is your best friend. There's no better way, particularly if it's a person that needs a lot of pressure, that you can get your biomechanics set in such a way where you can get as good a leverage as possible and feel as safe as possible. Because I mentioned even with my dad with the spinal fusion, can't put him in prone, but I can still do all of this stuff in sideline, and it's not a thing. So, gotta try to have your x-ray vision here. And this is what, if I could build the layers of all the muscles that come over and dive in like a seam from superficial, deep, all the way down to these paraspinal muscles. That the muscles of the back kind of, think of them like they're rounded tubes that have a seam here. And then all this stuff, look at psoas, it's right there. So the connective tissue anchor points, they tend to share points of insertion, and it gives them more stability. What it also tends to mean, though, is if one of these structures starts, being ornery, it'll cause a chain reaction. The lateral raphe, that's an R-A-P-H-E, I think, means a seam. The abdominal muscles, transverse abdominis, internal, external oblique, they all come over and dive in and attach. All the muscles of the spine, they kind of feed into that connective tissue framework. Psoas feeds in. And then that's quadratus lumborum, right there. Quadratus lumborum attaches, as you can see, up on the iliac crest. Predominantly is a lateral flexor, abductor, and it even attaches onto the first floating rib. So it can get involved in odd rib-related breathing pattern, everything. A true connection from your ribs to your pelvis. The quadratus lumborum. So you have to visualize that this is also right there. And then more and more stuff on top of it. Thus, the best way to interface with all of that at once is here, not there. And not even here. The best interface for getting most of this interfaced with, I say words that gets trapped in my vocabulary, is here. And since I have this as a visual guide, what I then get to use, just like how I was talking about using the base of the skull as at least a point of contact so I can redirect my pressure and be more precisely on the suboccipitals. Here what I use is bumping into the iliac crest, but then not pushing more into it. I bump into it and then dive down and start adjusting where my pressure is going to be. I can go more anterior and lateral. There I'm more likely to be interfacing with like the obliques and maybe even psoas. So this is a case where we can affect psoas without even doing the aggressive manual release piece. So sideline, the nicest way to do any of this, the safest way to do any of this, and the one where you get the most done all at once. So wow.
Now we always go from behind.
Mhm.
Do you ever go in the front and then
I
purposely hit the
there are
release?
I have seen for this
Yeah.
going for, so instead of supine coming down on top of psoas or iliacus,
No, like in sideline though, like how you're
Mhm.
usually behind them.
Yeah.
You go from where you
not
are
for
now.
that part. I've seen for psoas release
Okay.
coming in like this, just a targeted. Let's say it's a case where I couldn't lay a person supine,
Yeah.
then yeah, you could come in more targeted here. Just like how I've seen people do like shoulder releases, like subscat
Yeah.
and pec work.
Okay.
By coming over to the other side of the table in front of the person, you can get a lot of the anterior stuff done in sideline. But it is not my most practiced way of doing this. Thus, I'm not going to be as skilled at it. So typically for this, I do things here and then turn people on supine and get the rest of it. But yeah, just like a really good sideline massage, there's no reason why you couldn't get the quads, hip flexors, pecs, everything in sideline. So I know it ends up being the thing that gets the position that gets used the least, but it's not just for prenatal. God. Here, if I come in, hit the top of hit the iliac crest, and then go down, pretend I'm a magician. I'm gonna, saw him in half. Not that aggressive, but my motion is gonna be, do I track more anterior or more posterior? And then elbow angle again. If I'm coming straight down on the side and going anterior, I stay real flat because I'm just trying to cover as much of that space as possible. And then it's a whole dialogue with them. Which one is more of the thing? Are we on the spot? Is it this? Is it that? Is it this? Tiny tweaks. And y'all can appreciate the difference of being right next to the thing and then right on it. And then the pressure being just a little bit too much versus too little and it being just right. All of that is really only accomplished by getting them to tell you. You gotta be like, a little bit more that way, a little bit more this way. I go, oh, just a little bit more that way, and I just the tiniest little pivot, and now suddenly I'm on the thing, the goblin that's causing all this problem. Now, if we keep going posterior and increasing our elbow angle and deflection, it will position my contact point more posterior, and now I can start getting on those lumbar rector spinae and look at the orientation of my elbow and how I can more easily get into that nook of L5, S1, kind of the SI joint. Well, we'll call it SI joint, but really that's over here. But when people have SI joint dysfunction, this is an important place to make contact. So with especially one-sided low back dysfunction, if the symptom is predominantly on one side, I usually try to distinguish, is it more lateral or more posterior? And I just find out either through palpation or through their words of feedback. Here, here, here. And that point, too, what's really nice about this position is if they want more pressure and you're having difficulty, and I had some giants that I was working with, they could roll back into me and help with the pressure delivery. And even it can be finding the spot. Maybe I'm just the anchor and they're rolling back into me like the grizzly bear. Like, there it is. And then all that movement that they're doing at the lumbar spine and the pelvis, pretty much it's part of the muscle energy technique, right? So the positioning tricks really tend to be getting them further to the edge of the table. Ideally, they're closer to the edge of the table. That makes more room for this bolster over here anyway. So trying to remember. I still forget, and then I have to have him scoot back over to me. It's not that big of a deal. Like, you know, I'm here. I've done my neck and shoulder work, suboccipital release. Here we go, coming around, and in my routine, typically I've done the superficial warm this all up in prone. If I had not massaged the back at all in prone, then what should first happen is undrape here, have him roll a little bit forward for you, and then come in with some massage application to at least get the superficial stuff warmed up. To reinforce that, I keep on hitting that. They roll a little bit forward for you. You can get graceful and good at basically anything you practice. I find it easier actually here to use a soft fist, and that's the one case we're going downhill like this. Works really good for me. I just find the spine and then sink in and let gravity win. I can't have too much lotion, basically almost no lotion at all. But I just can come in and I can just turn this into what feels like everything being opened up that way. I can't do that in prone. So this ends up, to me, feeling spectacular. This feels like a better back massage to me than the back massage in prone. But it's not big flowy strokes either. You don't have to be doing you can sprinkle that in if you want, but this has to be pretty methodical if you're gonna do good body mechanics with it. Find the spine. So again, you can see how I can get right along the edge of that scapula. Using the side of your knuckles as kind of the main compression point will give an edginess where you can also like focus on spots where people want a lot of pressure. The whole rhomboid, serratus posterior superior area, this line of the scapula thing that they want you to work on aggressively, or the muscles up and down the spine, erector spinae. I can hold on, I can be here, work here. That's usually pushed out a little bit, and I can get kind of that sense of when people try to pull people's scapulas off their body. I do not like doing that to a shoulder joint, but I can get that same effect right here. And my hands right here to just give them a nice trap massage. Pull down. If this hand can come over and just pin this side as I pull down, I'm gonna get some myofascial lengthening. And it feels nice. I can work my way all the way down, and a soft fist could be your tool for this area. But I'm gonna show forearm as well. Right, then after all that's warmed up, come in, sink down, track more this way, or come in, and I can get real targeted. This is the one time where I do use my olecranon. Try to get right there in that nook. Cool thing here, because they're not pinned against the table, I can then ask them to just do little rotations with their hips. I can throw in some humor, but like, you know, pretend you're at a luau or doing hula hoops, you know, and little rotations of the pelvis, and then they're in control. They can either kind of roll more into you. We can coach more precise things related to positional release. While I'm pushing here, so my pressure, my contact point is here, 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 whatever. I can just have them roll that pelvis around, find a position that makes it more comfortable, hold that for a while, and then relax. There's your positional release. We're going into muscle energy technique zone. My shortcut is that whole lift the bottom leg, activating the opposite side adductors. There's a co-contraction reflex that occurs here related to balance. It's this whole thing. When I do this, I'm mostly using this and this to hold me upright. A little bit of this too, of course, but there's a really strong connection between your adductors and the lateral lumbar everything. And I've had many cases, by the way, where there's symptoms here, I work here, and it gets better, but it doesn't feel like it's really going the extra mile. I have to work on the adductors. There's something something locked in between the two of those that's causing noise. So lateral low back something, you can use the adductors with this action as a great muscle energy technique. But also be aware, you can sometimes get a really big piece of the puzzle solved by working here. Let alone high hamstrings, glutes, there's so much. Sideline, amazing. Now for firing pattern stuff, is the one time that you'll see a different orientation of the body, and that one gets shown specifically, typically, about releasing quadratus lumborum. If you want the shortcut, do it here with them positioned like that, lifting the bottom leg. You will get a contract, relax, muscle energy technique pulled off. If we're thinking firing patterns, then I have to swap the bolster. Yeah. Come on, hip. Come in. There we go. And I think a big reason why the therapists don't like to do this is because it's messy to get the bolster back over there like that. You gotta take it out and come around and get the legs swapped and stick this back under, and it's annoying. But if you were to do maybe all your massage and sideline, not such a thing. Now here's your position for assessing hip abduction firing patterns. I'm not gonna spend too long on that. There are other videos for that one, and we've talked about that. The action that's supposed to occur here when I go in for my amazing kick power is gluteus medius, tensor fascia lata. It's okay if they co-contract, but here, this should be first. Glutes should always be the power mover in abduction or extension and hyperextension. So just always think glutes. In extension, hyperextension, it's glute maximus. In abduction, it's glute medius, minimus TFL. But you'll be palpating here, just superior to the greater trochanter. I should feel that kick on before that. And if this is kicking on first, well, there's the story. The low back's working too hard when the hip moves. Wow, we gotta solve that. Thus, I do the exact same application, and then what do I have them do? That'd be cool. But no, it's lift this one. They work, both will work at releasing this, okay? But this one is the one you bring out when it seems to be a bigger problem related to like hip function messing with low back function and something else. I use this more in athletics. I use the other one more in like my typical clinical practice, okay? So that's the way you get to it. The biggest thing is you need one of these, and you gotta tell a person to scoot further over toward you, and sometimes have them roll forward, sometimes have them roll back. Have pillows so that they're actually gonna be nice and comfy and stable and lined up.
So they couldn't just lift their legs from the other position? It needs to be more extended, is that what?
Yes, because that doesn't replicate the action as much. You can kind of pull it off, but you end up always inadvertently doing some kind of rotation thing. I wouldn't say it's wrong. Arguably, muscle entry techniques, inhibitory pressure plus movement, which causes what you're pushing on to engage. So as long as that happens, because if it's doing that, that's weird too. So I could be telling the muscle, just stop thinking you're all about the hip. Calm down. Just be about the low back. You guys should be about the hip, one way or the other. You shush, you wake up. However you pull that off, and you can invent your own amazing technique, make an acronym and go sell it. If you can find it, go for it. My technique is sustained stable compression, SSC. Just squash it and then have them move it. There's lots of terms for compression plus active movement. What I don't think it's taught enough is the body mechanics a therapist needs to hold that compression long enough to actually get the result you're looking for, right? And when it's not super pokey and hurts. Imagine somebody that has a lot of bulk and muscle tone and you're coming in with your fingers trying to pull that off. It's a bad time. You have got to be able to figure out a way to position yourself so you can come in, and if you have to, get a step stool and get higher so you can come down more directly. If you have a hydraulic table, this is when you bring it down. But compressing anywhere here, even down to the SI joint area, and having them activate the opposite side adductors, what I like about that the best is that it's an easy thing to say to the client. I have to change the positioning, and asking anybody to just lift that leg. Their hip is dislocated. Here we go. I have not found a person yet, and these don't have to be big, it just has to start. I mean, this can be just enough for these to engage. You will always feel a kick on there. Just so easy, why the heck not? So if you're gonna take anything from today for low back stuff, it's remember this plus that is probably the easiest and safest intervention. And you can just change where you're targeting your compression and accomplish a lot. Maybe it's a little bit of everything. So you need to have your compression be more anterior, couple activations, and track your way more posterior, couple activations. Roll your pelvis around in a little hula hoops. All right, other side, we'll see what happens.